last time we started with the, we finished with the discussion of, we went through hypothalamus, right? Being the major regulator, right? The upper boy. So we would put hypothalamus right here. Come on, dude. Hypothalamus would be right here, and it would stimulate anterior pituitary in different fashion, and then anterior pituitary would produce a bunch of hormones. And we talked about anterior pituitary major hormone. I wouldn't say major, but the one that has direct effects in the body, the growth hormone, right? Its direct effects is pretty much generating blood glucose and breaking down fats to free fatty acids. Okay, so depositing energy molecules, I would call them energy molecules, carbohydrates or fatty acids in the blood, so they become available source of energy for cells. And remember that it stimulates insulin-like growth factors produced by liver, okay? And those insulin-like growth factors in turn stimulate a lot of stuff that we call altogether growth. Growth of muscles, growth of the bones, and here glucose and fatty acids become handy, because for growth you need energy, and here's your energy. Now here's, we chat about the rats being, you know, horrible, like a pound-sized rat, and major stimuli, the growth, for the growth. It's exercise and sleep, you know, for the healthy people. We all not getting enough sleep, I suppose. Speaking of exercise, again, expecting to become bigger and bigger if you just exercise is not enough, because you have to supply building material to your body to grow, right? So if you just exercise and don't eat enough food, you're probably going to be losing weight rather than gaining muscle volume, you know. That makes sense? It's kind of it was a quick review. Now, the pathologies. You've all seen them. So basically, you can classify them based on when there is an overproduction or underproduction of a growth hormone. And that would be applied to virtually every pathology associated with an endocrine system, right? If you think about hormonal regulation, your hormones must be just right. If you have too much of anything, it's going to screw the body's regulation up. If you have too low, same effect. Does that make sense? So if you think about hormonal pathologies, you can just think quantity. That's it. Just quantity of the hormone. Is that too high? Is that too low? Right? So in case of growth hormone, if it's too high, it can be too high from the very beginning of life, during childhood. And that would produce effect that we know as gigantism. Okay? So those children will grow. They will grow unproportionally. They will be, I don't know, 9 feet tall. Okay? Now, what is the problem? What do you think? Yes? True, yeah. Your organs too big. And there's one, yes. Oh, yeah. Oh my God, yes. Actually, for every tall person, for every extremely tall person, one of the most common injuries is Achilles tendon injury, because that enormous, usually those people are not extremely thin, they still weigh good 200, 250 pounds. They have to carry, and especially, if they move around a lot, if they exercise, that weight, which is elevated, right? So the center of gravity is elevated. To stabilize it, those tendons will work extra and they can get injured. So they have a lot of weight with elevated center of gravity, so their bones and their tendons are prone to injuries. But there's one organ that is made of muscle. Heart, yes. And they develop cardiomyopathy. So their hearts are enlarged. And unfortunately, people with gigantism usually die in fairly early age. So we talk about late 20s, early 30s. A lot, you know, there are a lot of different types of pathologies. There's the group of diseases, which I don't remember the proper name, that are associated with abnormalities in the connective tissue development. You may see people with extremely long legs, long arms, long necks, very tall people. This is the problem with the collagen synthesis. They may live very long and, you know, successful lives, okay? People who are hyperflexible. It's a group of pathologies associated with connective tissues that have nothing to do with endocrine system. So that's childhood. In adulthood, acromegaly. So you can see on this image here the progression of acromegaly as the levels of growth hormone increase with age. At age 9, the person looks absolutely normal. At age 16, if you wouldn't be aware that there is an increased level of growth hormone, I bet you wouldn't say there's something wrong with the person. But by the age of 33 and then 52, you can definitely see the enlarged bones, especially bones, the arms and facial bones become bigger. And it's a very characteristic appearance of people with acromegaly. They're not, again, people aren't dying, but it may cause cardiac, not so much, no, but cardiac consequences again. Because the muscle grows, yes, the muscle grows. Now, you can technically mimic acromegaly, and some athletes do that. When they take growth hormone as the performance enhancement drug. The symptoms, the external symptoms in terms of appearance are going to be very similar. But what else? They're going to develop type 2 diabetes. Can anyone tell me why? What is the, huh? You're gaining weight, but if you're an athlete, you're not going to gain fat. But look at the direct effect of growth hormone. What is the direct effect of growth hormone? Blood glucose is constantly elevated. And when somebody has a blood glucose constantly elevated, we will discuss the mechanisms when we get to the pancreas. We will discuss how it works, how type 2 diabetes develops. It will actually lead to type 2 diabetes in the long-term perspective. You know what's the sad part about growth hormone as performance enhancement drug? In multiple trials, there's no apparent benefit. I mean, if you shoot yourself with testosterone, you're going to grow muscles. That's it. You know, I mean, there's going to be side effects, but it's going to give you benefits. As performance enhancement drug, growth hormone has very controversial efficiency. So it's not, yeah. Yes, it may help you heal faster, but so can other anabolic hormones. So with more targeted effects like testosterone or other androgens that stimulate protein synthesis specifically. And, you know, I always bring up the Adrian Peterson from Vikings, you know. This dude was without ACL one season, and he ran second in the history of NFL second season. They claim there was no performance enhancement drug, but I can hardly buy it, honestly. I mean, in a year, give me a break. You know what they say about doping? It's not that they don't use it, it's that nobody caught them. So they're good. They that good. What if it's too low? Now this would cause so-called pituitary dwarfism. So this gentleman, I don't know his name as an actor, but Mini-Me is the guy that actually has pituitary dwarfism, underproduction of growth hormone. Okay, it can be treated with injections of growth hormone. In a childhood, yeah, if growth hormone is too low, you can do that. Do you want to do that? It's a different story, because messing up with endocrine system has far-reaching consequences. Those of you who never watched Austin Powers have probably, some of you may have seen Game of Thrones with Peter Dinklage playing, I forgot the name of the character. You know who I'm talking about, right? That little funny guy. So that little funny guy doesn't have pituitary dwarfism. Again, this is the pathology of the connective tissue. He has achondroplasia, which means his all his I blanked on the word. Sorry. Cartilage. All his cartilage underdevelops, and that determines why he's not very tall. Okay, other than that, growth hormone-wise, he's normal. Now, what can cause these diseases? In a childhood, it is usually a genetic abnormality. Gigantism or dwarfism is usually genetic. In adulthood, acromegaly can be due to the tumor in hypophysis, tumor in the pituitary gland. Tumor can be benign, non-cancerous, or cancerous. Well, that's a different story, right? But tumor, just you have more cells that will produce more hormone. What can cause low levels of growth hormone during adulthood? Any ideas? When you're an adult, you had normal levels of growth hormone, and now you have low. What can be a culprit? Any ideas? Not really. Much simpler. Much simpler. So you have a gland that should produce it. So the gland is what? Gone. Well, trauma. Trauma very often, if it's a trauma to the head that physically disrupts parts of anterior pituitary gland. I mean, it's pretty much physically destroyed. That can cause low levels of growth hormone during adulthood, and that would lead to all different kinds of stuff. So lethargy, okay? Usually obesity, so there's no mobilization of growth. And since it's not usually selective only to the growth hormone, the whole function of anterior pituitary gland is compromised. That will have the avalanche effect on other hormones. This person will become lethargic, sleepy, without libido. Okay, it's really inactive. Any sorry, any questions on the, yes? Oh, absolutely, yes, of course. And that is example of the gene expression. So gene expression is regulated when you grow. Growth hormone is produced in the large quantities. When you become older, it is not produced in large quantities. So you don't grow all your life. Does that make sense? Next gland we're going to talk about is thyroid. So this is where it's located. If you would look at those four, I see two gentlemen, one lady, and one model, second from the left with the guts out. So I cannot say if it's a lady or if it's a gentleman. but all of them have pretty noticeable beige thyroid glands. You see the blue cartilage on the neck? Right under the cartilage. It's a thyroid cartilage. There's a beige gland, large gland. Okay? That's a thyroid. Largest of the primary endocrine glands. So it's bilateral to the trachea. It has two lobes, the right and the left lobe, okay, that are connected by isthmus. That isthmus, actually isthmus from, I don't know, Greek or Latin, means neck. It's just neck, isthmus. So this is the spelling. You can see it right here. Isthmus of the thyroid gland. Okay, it's highly vascularized, obviously, because you need to release the hormone into the bloodstream. Right? On the microscopic level, we're going to look at it. Remember when we did in AP1, when we looked at different types of tissues? You looked at cuboidal, simple cuboidal epithelium. And classic example of simple cuboidal epithelium is a thyroid gland. Simple cuboidal cells, the follicular cells, which you can see here, line up the interior surface of large cavities called follicles. So this is a follicle, this is a follicle, this is the follicle. And those follicular cells line the surface of the follicle, right? Follicles are filled with so-called colloid. It's like a gel, okay, that has a lot of the protein called, and we'll get back to it, thyroglobulin. Okay, so follicular cells, you can barely see them here. Follicular cells are the ones that produce thyroid hormone. And thyroid hormone has many aliases. It's called thyroid hormone, thyroxine, T3, T4. It's just different names, so you can find them all over the text. Next to the follicular cells, you can see parafollicular cells. Parafollicular cells produce another hormone that you probably are familiar with. This hormone is called calcitonin. Remember when we talked about bone metabolism? Calcitonin, when blood calcium is too high, calcitonin takes the calcium from the blood and deposits it in the bones. Okay? So those two hormones, although produced by the same gland, have very different effects. I mean, they regulate completely different things. One question that students pretty much always have, very tempting question. Do we have to be able to distinguish between follicular and parafollicular cells, either in the picture or on the microscopic slide? The answer is no. Come on, it's you have to know the difference in function, but not, I will not ask you, come on, this is what? Follicular or parafollicular? Okay. Any questions on the anatomy? Let's get to probably the most complex part of the thyroid gland function. How this damn thing is synthesized. So two hormones. Thyroid and calcitonin. Thyroid hormone can be present in two forms. Thyroxine, T4, and triiodothyronine, T3. When we will talk about regulation, I will refer to both of them as the thyroid hormone. All right? Those two forms, they have same effect. They slightly different in terms of the chemistry. So we're going to chat about chemistry. We're going to chat about synthesis. I will tell you what you must know and what you don't have to know. Chemistry is, in my opinion, fascinating. You start with amino acid, typical amino acid called tyrosine, and then set of enzymes. Well, peroxidase adds, that's the first one, adds iodine residues to the tyrosine. So I have tyrosine molecule with either 1 or 2 iodines. When these two molecules interact chemically, they form this form of triiodothyronine. And then, in some cases, when these two molecules are combined, they form thyroxine. So essentially, what is the difference? Can you notice the difference between this, this, and this? What is the main difference, and actually the only difference between these three molecules? Yeah, T3s have 3 iodines. Thyroxine, T4 has 4 iodines. That's why 3 and 4. Make sense? Okay? So that's why we call them different names. That makes sense? Now, what happens in the thyroid gland? How the synthesis is partitioned throughout different cells of the thyroid gland. Iodine gets from the blood, okay? It's actually transported actively into the follicular cell. So you see the active transport of iodine. It goes through several hoops. It exists in the blood in the form of an ion, so form of negatively charged particles, so it has to be oxidized, and it's eventually it is oxidized to iodine, and iodine is in the follicle. So this is where the iodine is. Okay? Iodine is trapped in the follicle. And another thing that exists in the follicle is thyroglobulin, major component of that colloid. So have quite a significant amount of iodine, a buttload of protein, and this protein has as a part of it tyrosine residues, this exact residues. You follow me? So what happens next? I'll get back to the whole process. We'll go through that once again. What happens next? Iodine attaches to tyrosine, so all this chemistry goes on. Tyrosine remains, as it becomes iodinated, it remains attached to the molecule of protein, to the molecule of thyroglobulin. Eventually, thyroglobulin gets into the lysosome, where tyrosines are specifically chopped off. Okay? So these guys chopped off and end up in the blood. It's all a lot of words. Here's what I'm going to do. I'm going to play in front of you the synthesis. Okay? So let's start with, so this is going to be follicle, okay? And I'm going to be thyroglobulin. I'm going to be that protein, okay? Does that make sense? Good? Now I will ask Andrew to help me out a little bit. This is going to be follicular cell. Okay? You staying with me? It's probably going to be a bad idea, but I will try it anyway. It's going to be follicular cells. This is going to be iodine. Can you hold it for me, please? So iodine now is in the blood. I'm thyroglobulin, and that's tyrosine residue. Okay? So iodine gets into the follicular cell. Okay? And then I get it into the follicle. So it's now in the follicle. Well, this hand is not part of me. Okay? So iodine sticks to the tyrosine. Okay? Magic. We're skipping some steps. Now, thyroglobulin and thyroid hormone attached to it are still in the follicle. Alright? What happens next? I get into the follicular cell, to the lysosome. Enzymes chop it off. So this is now thyroid hormone separated from the protein molecule. It gets in the blood and wherever. Does that make sense to you? Pretty much. It's like a plant, okay? To make things. It gets tyrosines being chopped off from it. Well, since I value myself a little bit, technically speaking, I should be all in the lysosome and I should be all broken in pieces. Okay? So protein molecule gets destroyed. Okay? Does that make sense? The idea is that it is sort of just a carrier for the chemical reaction that happens. It carries tyrosine, which then gets the iodine. And this whole thing, including me, in the lysosome gets destroyed so that that thyroid hormone can go into the blood. Does that make sense? Now, what you have to know. You have to know this. You do not have to know all chemistry details. Alright? I'm not going to ask you in which position iodines are. Right? I'm not, yes.
So what's the protein that you refer to as being used to carry and transport?
Thyroglobulin. So this thyroglobulin, I will spell it better. Thyroglobulin is the protein that is used for the transport and stuff. Okay? Does that make sense? So if iodine goes from the blood into the follicular cell, from follicular cell into the follicle, attaches to the tyrosine that is on the thyroglobulin. Iodotyrosines combine, form thyroid hormone, which is still on the thyroglobulin. Thyroglobulin with thyroid hormone attached gets into the lysosome, gets chopped off, thyroid hormone is released, gets in the blood. Okay? What does it do? BMR. It just increases your BMR, basal metabolic rate. It can be measured. What would you say is basal metabolic rate? How would you define it? Take your time, think about it. Energy. Okay, very important word. Energy. So this is about energy. Now, let's develop on it. So if it's energy, what does it mean basal metabolic? The lowest, yes. So it's the lowest. Would Males, okay, I'll try. I don't want to be very, very personal with this. Well, Hunter is obviously taller and bigger than I. Would he and I, would we have different basal metabolic rate? Yes. So, what it depends on? Body weight, yes. Now, if you would compare me to anyone who does CrossFit, or better say, you have CrossFit athlete that weighs 250 pounds, and absolutely non-athletic male who weighs also 250 pounds. Which one of them will have higher metabolic rate? Yes, one with a higher muscle proportion, right? So basal metabolic rate will depend on the size, will depend on the body composition. What else? What is me and my wife? We're going to have different basal metabolic rate. Yes. Even if we will drop to the same body weight, as close as we can get, we're going to have different basal metabolic rates. Does that make sense? And it's going to be defined as amount of calories per gram of body weight. Turns out that this 2000, you know, when you read the label 2000 calorie diet, it kind of gives you an idea for about 170, 180 pound male. That's how many calories I would spend if I would just lie down the whole day, not moving. So for basal metabolic needs. That makes sense? So thyroid hormone can increase it. Okay. So what we're going to start with is we're going to talk about the regulation. You start with hypothalamus, right? So you have hypothalamus. Hypothalamus pretty much senses. It can sense two things. First, necessity to increase the metabolic rate. We'll get to that. Second, the low levels of thyroid hormone in the blood. Let's say your metabolic rate is low. Hypothalamus senses it, and it signals to the anterior pituitary. It releases thyrotropin releasing hormone. Thyrotropin releasing hormone. This is thyrotropin releasing hormone that acts on the anterior pituitary. What will anterior pituitary produce? If it's thyrotropin releasing hormone. Thyrotropin, right? It's going to produce thyrotropin. Another name for that hormone is TSH. So thyrotropin, or another name, thyroid stimulating hormone. Does that make sense? Now if it's thyroid stimulating, what is it going to do? Stimulate thyroid. Okay? That's what happens. It interacts with its receptors on the thyroid follicular cells. Stimulates release of thyroid hormone. Thyroid hormone increases basal metabolic rate. Increased basal metabolic rate is sensed by the hypothalamus, and negative feedback shuts down thyrotropin, TRH, shuts down TSH, and shuts down thyroid hormone. When you think about it, you really have to think about teeter-totter. Okay? They constantly produced, and the levels constantly change. Okay? In a certain range. Okay? That's important. Range. You have slightly increased BMR, thyroid's going to go down. You have slightly decreased, thyroid's going to go up. Now, when you have, that shows you how basal metabolic rate, these two graphs, respond to single injection of thyroid hormone. You see the increase of basal metabolic rate. When BMR increases, it then goes down. You have no extra thyroxine supplied. And that basal metabolic rate is not directly proportional, but shows dose dependence. The more thyroid hormone you will provide, the higher basal metabolic rate is going to be. Does that make sense? Now, before we get to signaling, basal metabolic rate, high basal metabolic rate, which observable effects it would have on your body? Temperature, heart rate. So what's going to happen to temperature? It would go up. What's going to happen to heart rate? It's going to go up. What else? Yes, respiration will increase. What about blood pressure? Will go up. You're going to be like jacked up. You're going to be like Jason Statham in the Adrenaline movie. Okay? You're going to be moving all the time. If you would look at people with hyperthyroidism, they quick, they move a lot. They're also very irritable, like psychologically. It's a kind of a side effect of that. Okay, perspiration will increase. Well, we have a couple of professors in the department. If you've taken their classes, you know, Dr. Landis and Dr. Nussbaum, that usually use the ventilator, like a little fan, because they're always hot. We have a joke that they have thyroid problems. They don't, but obviously, you know, that's a higher basal metabolic rate. So you're going to have heat intolerability because you produce so much heat, you will not tolerate the warm environment. On the opposite end is when you have low basal metabolic rate, you have lower temperature, lower heart rate, all the processes, metabolic processes in your body will go down. Does that make sense? So if I will jump naked out in Alaska, okay, then I will be cold, and in order to maintain my temperature, my core temperature, my basal metabolic rate should change how? Should increase. I'm cold, I'm freezing. Initially it will go down because I'm freezing, but in order to keep my temperature up, my basal metabolic rate should go up. So if I'm freezing outside, thyroid hormone will go up. Does that make sense? Right? To bring balance, exactly. It responds to the fact that I'm freezing. It responds to lowering temperature. Okay? To maintain the core temperature of the body. Does that make sense? Okay. It's the fat-soluble hormone. So it signals through the receptors located where, if it's fat-soluble? Cytoplasm or nucleus. That's good. Now, here's the example of a question that I would never ask you. If I would ask you, thyroid hormone is the fat-soluble hormone, what its receptor, where would it be? I would not put cytoplasm and nucleus in different answers. Does that make sense? Because if you don't know the answer about nucleus, you can still think it through and say, oh, it's fat-soluble, so it's somewhere inside the cell, right? I will give you just one option, the inside of the cell, one correct option. So it's actually in the nucleus. It binds to the receptor. The receptor, in turn, binds to retinoid X. They form that huge complex. That huge complex binds to DNA and stimulates transcription. You get transcription, you get mRNA, you get mRNA, you get proteins. Now, do you think it's going to be a long process or very quick? Get in the cell, get in the nucleus, bind to one receptor. Long, yeah. Bind to another receptor. Bind to DNA, transcribe DNA, translate RNA, get your proteins. It takes considerable amount of time. So we take hours or days. But what is interesting about thyroid hormone is that in addition to so-called genomic effects on the genes, it also has some non-genomic effects. So it will open ion channels, alter the oxidative phosphorylation in mitochondria, work through second messenger system. So it kind of possesses both properties of fat soluble and water soluble. You may get confused about this, especially in terms of what's going to be on the test. On the test, if it says thyroid hormone is fat soluble, there's going to be the receptor. Give me the answer. What is the pathway for signaling? If you see a receptor on the surface, you say no. That's not about thyroid. No. Right? Did I make myself clear about this? Okay, good. Again, pathologists. That's I have a very good friend who is endocrinologist back in Shreveport, Louisiana. And I asked her once, what is the most common endocrine problem that she sees? And remember, this is South. First answer, I didn't even finish the question yet. She says diabetes. I say, what's the second? She says thyroid. It's two things, diabetes and thyroid. Most common endocrine problems that you're going to run into if you work in endocrinology office. So with thyroid, you may have either too little of it or too much. Okay. Now, one of the very common problem with the thyroid, so-called goiter, enlargement of the thyroid gland, and often it is called dietary goiter. So why dietary? When you buy salt, regular salt in the grocery store, which two kinds? Well, except for sea salt and what else do they write on it? Huh? Iodine. Yes, iodized salt and non-iodized. So iodine, it's a component of thyroid hormone, right? Now let's imagine that you have not enough iodine in the diet. Are you going to produce thyroid hormone? You can't. No. Really, you can't. You need iodine. Without iodine, this whole thing is in vain. Okay, you just can't do that. So you gotta have iodine. Again, you don't have iodine. You don't produce enough thyroid hormones. If you don't have enough thyroid hormones, and I'm gonna bring that axis here. So remind me, let's do a digression. In the very beginning, which part of the endocrine system senses low levels of thyroid hormones? Hypothalamus. Which hormone it produces? TRH, thyrotropin releasing hormone. Okay. TRH acts on what gland? Anterior pituitary, which produces thyroid stimulating hormone, which acts on thyroid gland, which produces T3, T4. Okay? What effects T3 and T4 have on anterior pituitary and hypothalamus. Yes, they inhibit them, right? That makes sense? That's, by the way, is hypothalamus, pituitary, thyroid axis. HPT axis. Does that make sense? You staying with me? Now, you have low levels, T3 and T4. What's going to go up? What's that, TRH? Good job. TRH can go up, right? What about TSH? Sure not. If you follow the logic of this axis, what should go up? Next. Yeah, can they? What was the condition, initial condition? Why they are low? Yeah. Can we make more? You don't have iodine. No, we cannot. Right? So they stay low, and those low levels will be a signal for hypothalamus and anterior pituitary to elevate levels of TRH and TSH. Now, thyroid stimulating hormone will act on one particular organ, which is thyroid gland, right here. And if you constantly stimulate it, it's going to grow. Because the response will be, I kind of make it anthropomorphic. Of course, thyroid gland doesn't think, but it's kind of, I've got to make more thyroid hormone no matter what, so I will start to divide, to grow. It doesn't have any effect, except for it becomes larger and larger and larger. Does that make sense? So in certain areas where there are nutritional problems, when people don't get enough iodine with food, this problem persists. Actually, it can be reversed by getting enough iodine in food. It will shrink the dietary induced goiter. Does that make sense? Another problem can come from a completely different situation called Graves' disease. In Graves' disease, which is autoimmune disease, people also exhibit enlarged thyroid gland. But the mechanism is different. So if this is if these are cells of thyroid gland, okay, and they have receptors on their surface, receptors for the TSH, okay. So here's the TSH molecule. That makes sense? TSH will bind to the receptor, will stimulate production of thyroid hormone. Does that make sense? Awesome. What if you have some other molecule that is not TSH, but works as TSH? And you do have such molecule. Antibodies, very special antibodies. They will bind to that receptor. Antibodies. Okay, they will bind to this receptor and will also stimulate a production of thyroid hormone. Does that make sense? So that constant stimulation of thyroid gland will cause the growth. Now, if you have constant elevation of the T3 and T4, what's going to happen to the levels of TRH? It's going to go down. Everybody understands why? Because of the inhibition right here. If TRH is low and you have inhibition of anterior pituitary, what's going to happen to TSH levels? It's going to be low as well. Does that make sense? So the patients with Graves' disease will have a very characteristic clinical picture. First of all, they're going to have high BMR, basal metabolic rate, which means higher than normal heart rate, higher than normal blood pressure. Okay? Blood pressure will cause this eyes that kind of pop out because of that blood pressure. Very, very characteristic appearance. Heat intolerance, because they produce a lot of heat by themselves. Excitability, irritability. Also, all these processes, high BMR, what it means in terms of energy consumption. It will go up, right? People have to use it. Huh? They'll burn through the calories. They're going to have decreased body weight. Okay? That makes sense? What I wanted to say. And on the blood work, you're going to see elevated T3, T4 and decreased TSH. Does that make sense? You're going to have very distinctive feature in terms of the blood chemistry that will allow you to diagnose Graves' disease. In Hashimoto's disease, it's an opposite. In Hashimoto's, the receptors, as far as I remember, are being destroyed, so TSH doesn't act on the thyroid gland. So levels of T3, T4 are low, which changes levels of TSH. How? Elevate the levels of TSH. But since there are no receptors, you're pretty much screwed. Okay? So those are two opposite, pretty much opposite diseases. Hashimoto's is hypothyroidism. Graves' is hyperthyroidism. Actually, getting back to the burning through calories. What do you think in some clinics thyroid hormone is used for? Yeah, and I think it's not the most brilliant idea. But actually some people use thyroid hormone for the weight loss. Yeah, it does. It does also a lot of other things, like growing thyroid gland, but depends on what's more important. So hypothyroidism, okay, we discussed the Hashimoto's, we discussed dietary goiter. Now, symptoms, that's what's wonderful about those two conditions. You look at symptoms, they exactly opposite, just 100%. Okay, so if this is hyperthyroidism, heat intolerability. Hypothyroidism, intolerance to cold. Make sense? Rapid pulse in high hyperthyroidism, slow pulse in hypothyroidism. So just think and compare those two things, okay? Pretty much person becomes sleepy, pretty much lethargic. Almost in some people, there's pretty much no thyroid function whatsoever. One of the side effects for this is hyaluronic acid and chondroitin, a component of extracellular matrix, start to bind to the proteins in between the cells. This will cause accumulation of gel-like substance between the cells, and essentially accumulation of fluid and swelling. So one of my students previously called this picture the mean lunch lady. Yes. Yes. Oh, well, so for hyperthyroidism, I see where you're coming from, sleepiness. Well, for hyperthyroid, they will be all excited, but it's going to be effective. They don't have enough sleep. It's going to be effect like being on too much caffeine without getting enough sleep. When the only reason why you are not asleep is because your heart beats so hard that you're pretty much jumping in place. It happened to me before. So you want to sleep, but you can't because you're moving. it doesn't mean that you're consciously moving around. That makes sense? You see what this is going to be, people are going to be slow speech, slow movements. They want to be warm all the time and things like that. Okay? Any questions on the thyroid? Yes?
The dietary aspect, would they return to normal levels after the diet?
Yes. Yes. When iodine in the diet is corrected, they're going to go back to the normal level. And actually, if you would look at pretty much all the foods that are produced in the U.S., if they salted with the iodized salt. So you have pretty much zero chances to run dietary-induced goiter, to develop dietary-induced goiter. This actually, it's quite an interesting thing. I would bet that this guy here, this boy, based on appearance, you can tell that he's of an Indian or Sri Lankan descent, Bangladeshi. Now, Indian diet, especially in the poorer, cohorts, does not incorporate a lot of meats and a lot of seafood. So it's pretty much going to be vegetables. And you're not going to get, if you don't salt it, you're not going to get enough iodine. Like people who, for Japanese fellas who are leading, I think they are first or second in the world in terms of the seafood consumption. It's Chinese and Japanese. They kind of share the leading in this terms. They're not going to have any problem. They can skip the salt, whatsoever, because they get enough iodine with the seafood. Now, one thing that I can't really stress enough, what you have to focus on when we talk about these hormones is that negative feedback mechanism. So going back to that axis here, just be able to draw it, okay? Really, you are going to have questions like, if levels of thyroid hormone are elevated, what's going to happen to levels of TSH? They're going to go down, right? They're going to decrease. If TSH goes up, what's going to happen to levels of TH? It's going to go up as well. Does that make sense? Know which glands produce them and what effects they have. Right? That's really, and it turns out when you just draw this flow chart, when you take the test and you draw this flow chart, you have 3-4 questions out of the way right there, because you have the answers in the flow chart. But don't memorize it. What I mean is, don't memorize increase-decrease relationship. Think. So we have low TH. Low TH will be sensed by which gland? Hypothalamus. Which produces which hormone? TRH. So if TH is low, levels of TRH will change how? Increase. When TRH levels increase, which gland they act on? Anterior pituitary. What will happen in anterior pituitary? What happens to thyroid stimulating hormone levels? They will go up, right? When they go up, what will happen to what they act upon? Thyroid gland, which will produce T3, T4, more of it. Why it's not a self-perpetuating mechanism? What T3 and T4 do to endocrine system? To endocrine system. They do something to keep themselves in check. They don't stimulate. T3 and T4, what do they do? Yes. They inhibit TRH release from hypothalamus and TSH release from anterior pituitary gland. Now, if I will ask you in exam to draw the axis, like HPT axis, please provide me with the insights what the hormone actually does in the end. Because if you draw everything like here without any effects, the thyroid, because I did that to give you the example of negative feedback, but thyroid hormone actually has effects, right? So give me an idea. It stimulates BMR. Okay? Otherwise, it's going to be an incomplete answer. If you just... My question would be, why the cycle is necessary then? We can just skip it altogether if it has no effect on the body. Alright? Parathyroid. Now, this is interesting. Parathyroid is on the back of the thyroid gland. Now, have you heard about thyroid cancer? Right? You've heard about it. So there are two ways to treat it. If there's a tumor. Like if it's, how can you remove the cancer in the thyroid gland? Huh? Yes, okay, you can radiate the cells. It didn't work. What else you can do? Yeah, you can cut it out. You can cut it out. The only problem with thyroid is location. Look at it. What's close to it? Oh yeah, blood vessels, like big ones. You cut that common carotid, you see those two red arteries that go on the sides? You cut the carotid, you're dead. Like 3 minutes and you're out. So it's kind of a tricky thing. You can't do that. You can't surgically remove thyroid. There's another way. Thyroid uses a chemical element. Which one? All the time for synthesis. Iodine. Thyroid uses iodine, right? We'll get. It uses iodine. You can take radioactive iodine, load it into people, thyroid, well, person, not every person. Iodine will go to thyroid, it's radioactive, and it will just almost literally burn it. That radioactivity from iodine will destroy all the cells. It can be done. It is a way to treat the thyroid cancer.
It'll get rid of just the cancer cells or like the thyroid cells?
The whole thyroid. The whole thing. Just thyroid's gone. Yeah.
So
You don't have one afterwards. You live on the thyroid hormone injections, which I consider better than dying from cancer. But yeah, that's a removal. That's a removal of the whole thyroid gland. The good thing is that it's not, you don't have risks associated with the surgery, right? You're going to be lighting up on detectors in airports some time. You're going to be radioactive for some time. Really, they have some warnings for that. But yes.
So if you did hypothetically like remove thyroid, and you said like you could do the hormonal like
Yes.
injection, but would that affect like your longevity or like anything else like that? Like assuming, let's say if you got it all regulated and it was like you were doing it as you were supposed to, would it be? I mean,
I would say no, but I wouldn't take my words to the bank right now. I never looked into studies on that. Probably not. Thyroid hormone, probably not. It may affect your physical appearance because you may become, the patient may develop like increased body weight, not because of the muscle body fat, because of slightly dysregulated levels. But why I out of nowhere started to talk about thyroid problem. When you remove thyroid, you remove this, the parathyroid glands. They're fairly small, okay? Usually there are 4, can be 2, can be 8. There's like capsules, and then the back of the thyroid gland. So if you have thyroid, you have parathyroid. If you don't have thyroid, you don't have this one. So they kind of come together, and that can be kind of a problem, and you'll see how these two conditions go together. So in the parathyroid gland, there are chief cells, or parathyroid cells. Well, you kind of see them here. Okay. So parathyroid or chief cells produce PTH, parathyroid hormone. Okay. And the regulation of parathyroid hormone is very simple. This picture here, I would say, is more complex. It gives you more details, but on the very the conceptual level, you have low calcium. It stimulates production of PTH, which essentially increases calcium back, right? That's it. That's your whole regulation. Now, when I say low calcium, which part, where? Low calcium where? Like in your leg, in your blood. In your blood / extracellular fluid, okay? Low calcium. Okay? So it maintains the calcium levels in the blood. That make sense? There you go. Calcium levels in the blood. Now how? And there are other cells, the oxyphil cells. We don't really know what they do. That's all you have to know about oxyphil cells, that we don't know what they do. Now, how can we elevate the levels of calcium in the blood? Before jumping to the answer, think about this. Food in the fridge. No, I'm talking about milk. You can drink milk, but I'm talking about different things. It's okay. Oh, okay. Not even food. Money. There are 2 ways to have more money. Can you give me 2 ways? Make more or spend less, right? You can either make more or spend less. Make sense? Same goes for calcium. You can either take it from somewhere and put it in the blood, or you can reduce the amount of calcium that's being lost from the blood. Does that make sense to you? Okay, awesome. So here are 3 ways. 1, you take calcium from the bones. PTH will stimulate osteoclasts. They will resorb the bone. Calcium will get in the blood. Are we clear? Second, you increase the amount of calcium that you take from food. Right? So, amount of calcium that is reabsorbed in the intestine goes up. Okay? You extract more. It doesn't mean that, you know, little dudes running around the intestine just squeeze your food for calcium. No. Say you have 100 molecules of calcium, hypothetically. On the regular basis, you absorb 10. If PTH is produced, you're going to absorb 20. Does that make sense? And the third way is, sorry, it's I was wrong in terms of the placement, because they kind of, so this is your calcium in the intestine, okay? Now this is getting calcium back in the kidneys. Normally, calcium is going to go into your urine. You're going to pee it out. If you have low calcium, your kidneys will keep it in. You will spare less. Does that make sense? So again, take it from the bone, take it from the food, or keep it from getting into the urine. Right? Now, these 2 things, osteoclasts and urine, are direct effects of parathyroid hormone. Absorption of calcium in the intestine is indirect. Parathyroid hormone first has to activate vitamin D, which then will increase reabsorption in the intestines. All right? Now, vitamin D, how can we get it? Sun. We can get it with the sun, or we can take it with the foot. Look out there. I don't see much sun right now. Okay, and the weather sucks. So I wouldn't spend a lot of time out there anyway. And we work. So we spend all that time inside. So our exposure to ultraviolet is limited until it's summer. Okay. So if you look at the foods that are produced in the States, again, bread and other stuff, a lot of them are enriched with vitamin D. Milk, even bread is enriched. Milk is, I think all milk is enriched with vitamin D. Another thing I told you before probably about experience in the Soviet child care, kindergarten. Winter is pretty long, like Ohio, but maybe longer. Starts in October, ends in April. And there's not a lot of sun. So kids were standing in front of the UV lamp in a cool looking shades and underpants only, getting the portion of UV light to get vitamin D produced in the skin. Make sense? They don't do it they don't do it now. Okay, if they did it to me, I was too little to remember. Because, you know, it's one of the biggest, most important parts of your life when it's like critical. Is when you're about like 1, 2, 3 years old, when your bones are fairly soft, but you already start to fight gravity. And if bones are soft due to the low vitamin D, calcium is not getting absorbed in the bone, kids often develop the bow-shaped legs, you know, different soft skeletal abnormalities. That's why when kids are sleeping, you know, they say, put them on different sides. When they're in a stage of the zucchini, you know, when they're like 3 months old, they still pretty much have the conscience of zucchini. You put them on different sides, so their head is shaped properly. We failed to do that with one of our kids, so his head is slightly awkward in the back. Seriously, it doesn't hurt in any other instance. You just see that skull is a little bit misshaped, a little bit asymmetrical, because of he preferred like sleeping on one of the sides and not another. Okay, when bones become stronger, then it's not that bad. Okay, we're gonna get back to the regulation of calcitonin after the break.